ready.
Okay. Okay, I will give you the countdown first and then you can start. So, sir, it's 3, 2, 1. Sir, we are live now. Over to you.
Good evening, everyone. Myself, Dr. Dronavali Lokesh Sai, Medical Affairs Department, MacLeods. As we all know, with the turn of century, CVD has become a leading cause of mortality. And India has the highest IHD burden in the world as compared to other countries, which leads 1.54 million deaths per year and 39.9 disabilities adjusted in the life years. So understanding the therapy and molecules also very, very important in the current scenario. So to throw more light on fixed dose combination, the DAPT and statins, we have with us Dr. Bilal Ahmed as a well-renowned cardiologist in Jharkhand. Sir is currently working as a Sri Narayana Hospital in Jharkhand. And it's my pleasure to introduce you, sir. Now, over to you.
Thank you. Thank you, Dr. Lokesh. So, can we display the slides?
Yes, sir. You can share your screen, sir.
Let us see the problem.
Just share the screen, sir.
Yeah, please share. It's not displaying.
No. सर आपने जिससे की थी ना पहले जैसे की थी ना वही सेम मेथड से कीजिए शेयर स्क्रीन के बटन पे क्लिक कीजिए डॉक्टर बिलाल
Yeah, is it visible to everyone?
No, sir. It's
Not yet?
Sir, आप Zoom की screen पे चाहिए, Zoom की particular screen.
Yeah, I'm sharing it. This is the topic.
Yes,
it's not
sir.
Coming.
Yes, your slides is visible. Sir, can you do the slideshow mode? Sir, can you do the slideshow mode? Yes, sir. Can you do the slideshow mode, please?
I did it. Again, I did the slideshow, but it's not coming on the screen.
It's coming, sir.
It's not visible to me.
Okay, sir.
So now it's visible to everyone?
Yes, sir.
Okay. So today, as Dr. Lokesh has told us about the role of statin, that is very important. The dual antiplatelet therapy in acute coronary syndrome. So that will be the topic of discussion. More interest will be regarding the role of statins, especially the rosuvastatin as compared to the other statins. So outlining the things which we will be discussing will be the cardiovascular death burden and challenge, the guideline recommendations, the rosuvastatin superiority of rosuvastatin to other statins, the dual antiplatelet therapy, and the anticoagulation with dual antiplatelet therapy or in place of antiplatelet therapy. And finally, we will summarize what we have achieved from this lecture. So, cardiovascular disease has been recently updated in Journal of American College of Cardiology that cardiovascular disease, principally ischemic, IST, and stroke are the leading causes of mortality in the world over. So this is a big challenge to every cardiologist in overcoming all these cardiovascular diseases to reduce the mortality and the morbidity due to cardiovascular events, that is myocardial infarction or the stroke. So renewed focus is needed now on affordable, widely available, and effective treatment strategies for cardiovascular disease. So this is a citation from an article that the lipidemia management, as per if we have seen the ESC guidelines, have never been up to the mark. So increase prescription of high intensity statins may represent a more cost effective area of focus to ensure greater number of patients meet their LDLC low density lipoprotein targets. So what we have seen earlier that people started statins in a very low dose that does not overcome or control or bring the LDLC levels to the target levels. There are certain factors which are hindering or which are challenging the inertia in a cardiovascular event prevention. They may be patient related, they may be healthcare or a doctor related. Patient is the medication side effects, or the patient is not tolerating medicine, the patient who already has got other comorbidities, who is receiving all these medications, whether it's diabetes, hypertension, COPD, that makes them very cumbersome to use statins, right on already too many medications. The costs. Second thing is forgetfulness, denial, or we see there is a communication gap, or there is the low health literacy or the poor awareness about preventing majors of the cardiovascular events. From the healthcare point of view, failure to initiate, titrate, or bring down the LDLC level in a particular duration or in a particular time, that is the biggest disadvantage right now we are having. More awareness about using these statins earlier in prevention of cardiovascular disease. So correlation between atherosclerotic cardiovascular disease and risk factors statin prescription, we have seen that atherosclerotic cardiovascular diseases in diabetics or people who are dyslipidemic, HDLC levels are very high, LDLC levels are very high, or patients who are smokers have a very high risk factor for cardiovascular diseases. So when put these patients on statin or an intensive statin, so underutilization of statins is a big risk factor that already we have described that people prescribe 5 mg of rosuvastatin or 10 mg of atorvastatin. They does not monitor or titrate doses in respect to the LDLC levels. If LDLC levels are not brought under control as far as the international or the Indian guidelines, you see if we take the LDLC levels from the international level, we should bring them below 75. And some Indian starting this Indian Lipid Association prescribed them, bringing them below 50. That is the real utilization of statins to bring cardiovascular events down by monitoring these LDLC levels and titrating the doses accordingly. So challenges in managing, as far as Indian data is concerned, is the access to the treatment, affordability to the treatment for ACS or the cardiovascular event or the secondary prevention. So if we see antiplatelets, people are using aspirin, very less clopid, certain level of 50 to 60%. There are beta blockers, ACE inhibitors, and very less AC statins. This is the data which is showing this managing of challenges in managing ischemic heart disease in Indian perspective as far as primary, secondary, or tertiary care levels are seen. So if we see aspirin has got almost 70 to 80%, 85%. Everybody at the primary, secondary, and tertiary care, but if we see statins, that is very less in the primary centers and around 60% in secondary centers, tertiary centers. So what are the guidelines? How should we use these statins? Nice guideline, National Institute for Health and Care Excellence. They give guidelines for ACS. ACS has to be managed with a dual antiplatelet therapy and a statin. These are the first line drugs that has to be given, whether it's a myocardial infarction with an ST elevation or unstable angina or NSTEMI. A dual antiplatelet has to be there. It is ecosprin, clopidogrel, and a statin. So managing these ACS patients with PCI, then again, dual antiplatelet has to be given with a statin. So how long that has to be decided will be decided according to the patient. So there are concerns of these people who have older age. One of the antiplatelets is Vasopressin that usually is not used in people who are above 75 years old. Either a ticagrelor or a clopidogrel can be known as a secondary antiplatelet. As far as the US or the Canadian guidelines, people from general population study where seem to have atherosclerotic coronary vascular understanding and reasonable. Majority of the other countries where we see people who are using the statins, they use them very less or they use them in a very low dose. So their dosage has to be high intensity dosage. So the Lipid Association of India, we see, recommends aggressive LDLC goals after ACS, which can be rapidly achieved with high intensity therapy. High intensity therapy actually means that we have to bring down, if LDLC levels are 150, we have to bring them down 50%. That means 75 in a 3 months goal. That is the level of statin we have to use. Either we use a rosuvastatin or a atorvastatin. So improving this cholesterol control in ACS definitely reduces the mortality and the morbidity in these high-risk patients. So Lipid Association India in 2020 have given an algorithm for ACS. They have used in certain groups where statin naive group, group 1, on admissions and a blood profile and monitor their LDLC levels or lipoprotein A levels. Patients with low to moderate intensity statins are to be given. Patients who requires intensive high intensity statins. Patients who have intolerance or statin resistance, where we can use resistamide or the newer drugs that we will be discussing in further slides. So after starting these statins, then we have to monitor after 2 weeks. LDLC goal has to be kept in mind that we might have to reduce it almost less than 50. And lipoprotein levels almost impossible less than 30. So ACS or American European guidelines, they recommend trying to reduce this LDLC levels up to 75 or 70, and if possible can reduce much more, less than more than 50% will be within first 3 months. So ESC guidelines for diagnosing chronic coronary stability. This is a different slide where we can see patients with moderate risk, patients who have diffuse multivessel diseases, who have diabetes, recurrent coronary events, peripheral arterial disease, recurrent heart failure, kidney disease, their statin dosage, and so this is the treatment of ACS, where we have the antiplatelet. First will be ecosprin, the second will be either clopidogrel or prasugrel or ticagrelor or rivaroxaban, which is coming in 26/7. That we can use the second platelet and anticoagulant 2.5 mg twice a day till up to 1 year as recommended by the US guidelines. So, chronic coronary syndrome, or PCI, clopidogrel is the preferred choice. And in acute, we definitely have the ticagrelor or prasugrel or a rivaroxaban. So, statins, rosuvastatin as a superior one, definitely it reduces LDL much far better than atorvastatin or other statins. So, LDL-C reduction has a very drastic and robust change due to use of rosuvastatin as a first line potential for acute coronary events. They have a high effective coenzyme A reductase inhibitor potential than the other statins. So high dose atorvastatin or rosuvastatin in patients with ACS undergoing coronary intervention, that was the meta-analysis where they definitely reduce the recurrent cardiovascular events or the mortality within the first 30 days. So rosuvastatin was atorvastatin in de novo CAD patients. That was shown that the treatment with rosuvastatin was 10 milligram, atorvastatin 20. Rosuvastatin was much better as compared to atorvastatin. So it was also confirmed on OCT images that the intimal this thickness, or we see the plaque modification or plaque remodeling much higher with rosuvastatin as compared to atorvastatin. As far as the hemodynamic changes of coronary atherosclerotic plaque after rosuvastatin was much better than this was done with the CTFFR. So this was the CTFFR guided study where rosuvastatin was found much better as a hemodynamic modulator than atorvastatin. Statin intensity, duration, achieving maximum benefits is the goal. So DAPT will anti-platelet that poll study in recent American College of Cardiology polling where majority of the people voted 1 year of DAPT therapy, around 38%, and 6 months was around 28%. Overall, the low number of thrombotic events and relative under perspective of ACS were due to DAPT for longer 1 year study. Recently, we have seen that there were no clear benefits of using the aspirin in patients who are diabetics, hypertensive, who disadvantages were more of bleeding risks were more as compared to the preventing the events of ACS. So risk of bleeding was higher. The antiplatelets in diabetics, hypertension, or others respective of coronary events was stopped because of their high risk factor. So if we see a pre-treatment in a patient who has to undergo some routine procedure, routine coronary procedure, then a ticagrelor 180 or a clopidogrel 600 with a low risk of bleeding, and the patient has a high risk of bleeding, then again we can use a prasugrel 60, 180 and clopidogrel 600 as a loading dose. So these were the antiplatelet therapy was severely hard. This is trained patients for clopidogrel versus ticagrelor, and then there was plateau was for clopidogrel versus ticagrelor. So clopidogrel was around 3 years as compared. So ticagrelor was superior. So we were the 1 year out on see the DAPT score or DAPT study that showed that the maximum benefit for the patients who had high risk of ACS or who had lasting with a multi-vessel disease, DAPT should be continued for more than 1 year. There were studies which showed that DAPT as ticagrelor can be reduced from 90 mg/BD to 60 mg/BD and can be continued for more than 1 year till up to 36 months. DAPT 1 year and DAPT less than 1 year showed that patients who received DAPT for more than 1 year had less coronary events, but there was a all-cause bleeding risk more ticagrelor continued. So if we see the clopidogrel as a second antiplatelet, we can see that it reduces the bleeding. It has a very less chance of bleeding as compared to ticagrelor or prasugrel. After as a second antiplatelet, it can be used in patients who have slightly milder risk of bleeding as a second antiplatelet. So post PCI, again, petrol therapy, oral combination plus antiplatelet, very high risk of bleeding. Never give a P2Y, so we escalate it to the single antiplatelet. We have a very high risk. Moderate risk, then we can use as a second antiplatelet. So why to de-escalate clopidogrel was only cause was high risk of bleeding. If we see escalation of an antiplatelet, then needs a thrombotic event. The patient who was on clopid as a second antiplatelet and has some thrombotic event, then change this clopid to ticagrelor or a prasugrel. So ACS, PCI preloading, we have seen risk stratification, then the bleeding risk scores. If there is no bleeding, then we can continue this DAPT with 1 year or more. And if bleeding risk is there, DAPT can be shortened to up to 1 month. Rather, it can be given for 6 months and they can get it to the moment. So the taking DAPT has again some post PCI events. It can be thrombotic patient for DAPT escalation and de-escalation according to composition. So cardiovascular burden increasing globally, especially in India. So renewed focus is on affordable and widely available effective prevention strategies. So prevention is better than cure. So preventing the coronary event prior to using a statin in patients who have high LDL levels, starting them on some statins and treating them to prevent cardiovascular events. So once the patient who had cardiovascular event has to be put on high dose statins and an DAPT therapy as far as it is nice ESC American guidelines or lipid guidelines. So rosuvastatin is highly effective in reducing LDLC as compared to other statins and very favorable modification of other elements. That is the pleiotropic effect of statins. So DAPT again a new era has been offered concept of precision medicine favors de-escalation continuous 12 months of this. Thank you.
Thank you so much, sir. Sir, very wonderfully shared, sir. We have received few questions, sir.
Yeah.
Where do you place this fixed dose combination in our clinical practice, sir?
When?
In ACS patient, post PCI, where do you place this fixed dose combination of statins and DAPT in your clinical practice?
Actually, there is a lot. It depends upon what sort of a patient it is. If we have a patient who had coronary event and we did a PCI to the patient, so these high dose statins should be continued at least for 3 months and check the lipid profile and with DAPT. Especially nowadays, we use either a ticagrelor or a prasugrel. If the patient has multi-vessel disease and the patient has other risk factors like diabetes and DAPT score is more than 2, then the combination of DAPT plus statin should be continued for till 1 year. After 1 year, if there is no coronary event and there is no recurrence of any coronary disease, then we can change it to a single antiplatelet therapy. And statin can be modified after doing a lipid profile in a patient of 3 months. If the LDLC levels we have achieved, then we can reduce the statins.
Right, sir. Sir, we also see that latest trials showing that shortening the duration of DAPT.
Yeah, we have seen various trials which are showing that DAPT can be given till up to 1 month.
1 month, and guidelines are recommending something extended.
But if we see the what sort of stents they are using, what sort of drug-eluting stents in these countries where the study was done with a DAPT of single month, does not make any difference in the actual events of coronary which happen after that. If a patient who has a single focal lesion, a chronic stable coronary disease, who underwent angioplasty, who has no recurrence or no coronary event during 1 month, can be thought of reducing a ticagrelor or a prasugrel to clopid, not altogether stopping it. If we see the poll in this ACC poll, that was they clearly have shown that 38% voted that DAPT should be continued till 1 year. So majority of the population of cardiologists right now or anywhere in the world is thinking continuing it till up to almost, if not 1 year, at least for 3 to 6 months. And then if they see there is no coronary event and the patient had a single vessel disease, does not have any risk factor of diabetes, hypertension or smoking, then the DAPT can be stopped. The DAPT can be escalated down to ecosprin and clopid rather than giving it ticagrelor or a prasugrel.
Sir, even some queries are coming like whether to use or aspirin or P2Y inhibitors alone, which can be preferred. Like that, there are few queries.
As a single therapy.
After the 2 months of DAPT, can we remove aspirin?
Aspirin never has been seen removed before 1 year. Nobody does it. Yes. Because aspirin definitely, as a single antiplatelet, will be a sole antiplatelet who has to be given. So the second one is an option with clopid, ticagrelor, and a prasugrel. So after 1 year, either you give a clopid or a ecosprin, makes a less difference. We might see people who are post angioplasties or post CABG are on clopidogrel because clopidogrel has some additional benefits to ecosprin. One is the gastritis. Second is the gastrointestinal bleeds. So they have a less event of gastrointestinal bleeds or a gastritis as compared to the ecosprin. Using a clopidogrel after 1 year as a single antiplatelet will be better.
Sir, what is final take-home message for the audience as well as
final aim is if we are finding people who have risk factors, especially I could say smoking. Smoking have a very atherogenic, very notorious atherosclerotic cardiovascular disease as compared to other risk factors, because these nicotine is endothelial damaging. So it creates that virtuous triad that gives result to ruptured plaque or ruptured coronary event. What we see nowadays, young people dying without any risk factors or without any comorbidities. So maybe their lifestyle, their smoking habits, sedentary habits, their dietary habits, they are giving rise to some sort of a dyslipidemic blood. So that dyslipidemia is again creating a havoc that is giving them acute coronary events which are not manageable. So controlling lipids with statins and keeping LDLC levels under control. I cannot say whether you keep it below 75 or 50, but if possible, keep it till 100. That will be the best thing in the field.
Sir, why the patient has to remember which type of stunt used for the PCI? Not required, sir.
Post PCI. Post PCI they have equally good results, but rosuvastatin definitely has been shown better this effect than the other statins. But I personally have seen that people who had been given 40 mg of rosuvastatin, as far as Indian population is concerned, tolerate less rather than 40 mg this atorvastatin.
Sir, with this we came to the end of this meeting, sir. We finally thank Dr. Bilal, sir, for enriching our knowledge as well as audience knowledge and answering the few questions of the audience. And from the entire MacLeod's team, I would like to thank you, sir. Soon we will meet in future, sir.
Thank you.
Yes.
So thank you, sir.
Thank you, Roshini.
So from here, yes. So from here, now I'm ending the meeting. Thank you.
Okay.